Bismillah ar-Rahman ar-Rahim. This is a nice case of a PVC ablation, which was very well planned. She's a 35-year-old female patient with ventricular bigamy almost, and the burden of 11% in Holter, although it is running in ventricular bigamy. The 12-lead ECG in the clinic showed it could be outflow tract either from the right ventricle or the left ventricle. We brought her to the lab. We started mapping from the right side. First, we have Dr. John with us. We recorded the PVC on a template in order to compare it when we ablate. Then we introduced a CS catheter. هتبقى هنا من هنا. We introduced the CS catheter in order to help us mapping inside the CS and up to the area of the summit. And you can see here, this is the PVC. The atrial electrogram is here. The V on the CS is late. Yeah. Dr. John is saying this is a fusion between the sinus because it was a late PVC. So the ventricular electrogram is here. We did not get it. Let's get the log. Okay. We are now in the waiting period. We ablated it successfully, so we are in the waiting period. We'll go with you through this technique because it's very important to have a strategy when you start ablating PVC. First, we start with the right side. We place the CS catheter here. This is the atriogram, ventricular, and we make sure that this PVC is the clinical one. Then we started mapping in the RVOT. John?
First, when we introduce is a mapping catheter inside the RVOT, we got a good signal from mid-septal area. And here we can see that we proceed in the QRS complex by about 32 milliseconds. Ablation of such point eliminates the PVCs for a while, and after that it recur by different exit, as we can see here. The transition in V3, which was RS highlighted in orange, now it is monophasic R in V3. So we suspect a change of exit. So we went to the aortic sinus for mapping.
We went retro the aorta in order to map. Meanwhile, the patient was fully heparinized. She received 5,000 heparin in the beginning, and we added another 3. Afterwards, when we the femoral artery puncture was done from the beginning, so the patient will be anesthetized, will not be screaming. While we were ablating in the RVOT, and we'll show you the fluoro, the patient had pain, and you have to expect this, and you have to be very careful not to ablate too much to do perforation. We have very good experience with this, and when we discovered that the ablation from the RVOT was not effective, it was partially effective, and it recurred, and then when it changed the exit and we got the monophasic RV1, then John went to the retrograde approach to the coronary sinus of
mapping of left coronary cusp was late because PQRS complex we was pre-QRS complex by about 15 to 20 milliseconds, while the junction between the right and left coronary cusp, here we got a very nice potential and proceeding the QRS complex by about 34. Ablation at such point eliminates the PVCs immediately.
Yes, we can go to speed one.
Yes.
So that you can see this. Yeah. As you can see here, this is the
here.
هنا عمل مارك على B3.
This is the start of ablation.
Yes. And immediately disappears PVC. In order to make sure that you are correct, you have to give waiting period, and you can see this is the 10-minute waiting period, and here this is the running EGM. Give us the screen of the fluoro to explain the sites. CS catheter in the left anterior oblique view, and we introduce it high up in order to map the area of the summit. And here the first ablation site, which is the RVOT. This is the ablation catheter, irrigated tip catheter, introduced into the RVOT just almost at the level of the pulmonary valve. Yes. Run this. Oh, here. As you can see here, this was the site which we got partial success. We got partial success at this site. And then and here this is the REO view, this is and the septum. And when we are in the septum, you have to think of what is the posterior to the septum is the coronary, the cusps of the coronary aortic cusp. Here then retrograde approach in the LEO view, as you can see here, this is this is injection from the catheter. This is something you make sure that you are away from the left main, and this is the left main and the LED. And the signal here was not that good, so we mapped at the junction between the left coronary cusp and the left coronary cusp and the non-coronary cusp. Yes, the combination between the left and the non-coronary cusp here, and that was the successful site which we saw. Get us this. Yeah, this is the REO view. As you can see, the catheter is very, very, very stable. You can see here, the catheter is here very stable. The aorta, the retrograde approach, and then it is at the junction, and it is posterior between the left coronary cusp and the non-coronary cusp. Next. That's it. We make sure that at the end, at the last picture, we made this to make sure that there is the left border of the heart is contracting. There is no effusion. We have spent 12 minutes waiting, and we can see here on the monitor there is no PVCs, and maybe you made 5 more minutes, and that's it. Thank you very much.